got a really punchy group of speakers this afternoon, full of lots of short, quick ideas of the kinds of things that might be happening that could help us with the psychosocial impact of what we're going through with the pandemic. So welcome everyone. If you could move the next slide on. So we're going to first move on to Beth Mcgeever, and I'll let Beth introduce herself in a bit more detail. She's going to talk a little bit about trauma-informed care in reference to the long-term plan. Beth?
Thanks, Angela. Hi everyone, I'm Beth Mcgeever. I am a programme manager in the adult mental health team at NHS England Improvement, and I'm just going to take a couple of minutes before we move on to the rest of the agenda and hear from all the great speakers that we've got joining us this afternoon to talk about trauma-informed care in the context of the NHS long-term plan. So can I just get the next slide, please? I also wanted to say that I feel like this is a great way of running things. Just I think all of the speakers are sticking to a single slide, which is fantastic. So just the headline message here. So the NHS long-term plan and associated mental health implementation framework include clear commitments to the use of trauma-informed approaches to mental health care and support. So by the end of the period of the NHS long-term plan, will have supported the establishment of maternal mental health services, additional trauma-informed support for vulnerable children who are either in or at risk of being in contact with the health and justice system will be provided, will pilot new models of care for women's secure care, improved therapeutic inpatient offer for adults in inpatient settings, post-crisis support for families and staff who are bereaved by suicide. Care and support for homeless people will be trauma-informed and holistic, and 6,000 children and young people will access sexual assault and referral services. And then just briefly to go back to the community mental health ambition. So 370,000 adults and older adults will access transformed community mental health care. So at the minute, we've got 12 early implementer sites across England that are piloting new models of care within the community for people with severe mental illness. And the intention is that those new models of care provide trauma-informed and personalised approaches to care. And this was just to set the context of how we began working with Angela and the NHS Northern Clinical Networks to establish the trauma-informed care community of practice. So Angela and colleagues from the Northern Clinical Networks have established the trauma-informed care community of practice, and that is really a forum for commissioners, providers, experts by experience, system leaders, local authority systems to come together and to talk about the importance of trauma-informed approaches to care and support, but also to share good practice resources, talk about enablers and barriers, and all to kind of get conversations going around the importance of trauma-informed care. So I will stop there and hand over to the next speaker, but I hope that was a useful whistle-stop tour to set the context for the collaboration platform and the community of practice.
Thank you, Beth. I'm going to talk a little bit about how this emerged from a summit that we had last year that I'm sure some of you were able to attend. We did, next slide please. And I think because we are looking at trauma-informed care from a kind of fairly relational perspective, we invited lots of people to produce stories of good practice. And from that, we analysed the themes that came out. Next slide. And so what I'm going to do is I'm going to apply that framework that emerged a little bit to how we might ensure that we're trauma-informed in our response to the epidemic. And I'm sure a lot of you have given a lot of thought to how traumatizing an epidemic is anyway. But I think what is concerning is that the literature is that it's one of the most traumatizing events that a country can have, because it's so widespread, because everyone is so affected, and it affects every aspect of people's lives. And in particular, I think one of the things that's so noticeable is those relational connections, that it's so hard when we don't see each other face to face. And I think this is a good substitute, although for me it's not exactly the same working online. Next slide. When I looked at the literature, I think there's a number of principles that we can think about in terms of what we know from the literature in terms of trauma-informed practice that would help us here. Firstly, there's something about avoiding duplication of work and fragmentation of services, so that we need to coordinate things across agencies in order to be able to get this right. Physical safety is really important, and the physical well-being of a population will in part determine the psychological fallout. We need to work with the supports and informal networks that we've got, and make sure that we use normalizing messages where we can, rather than pathologizing everybody for reacting in fairly predictable ways. We need to really think about having a needs-led system that's very flexible and agile and can respond very quickly to people. And next slide. Next slide. So that's just a photograph from the event, and these were the themes. There was clearly an interpersonal one, but there were also themes around how services are structured and the processes that they follow. Next slide. So this was the framework, just mentioned very briefly. The two things that were in the interpersonal category were, one is the style of leadership, being very empathic, transformational, collective kind of thing, but also that relationships, not just with service users, but also between staff are based on a bit more than mutual respect, but where things go wrong, there's efforts to repair that damage. In terms of structure, you do need sometimes specific interventions aimed at healing the impact of trauma, but there's also something about the way services are set up, sometimes very piecemeal, and that the interface between them isn't good, so people end up falling through the gaps. And in terms of process, I'm sure it's no surprise that safety and empowerment are there, but also this thing of human experience language, where we try to, as a psychologist, I'm sure I'm guilty of using psychojargon at times. So this isn't just about getting rid of a kind of medical language of trauma. This is also about allowing everybody to take part in the conversation about what trauma-informed care means. And so trying to use everyday language where possible was another theme. So if we move on to the next slide, I've had a think around what that framework might, the kinds of questions that framework might lead to when we're thinking about what our responses would be. And I've left them as questions because what I'm hoping is that this is the beginning of a conversation. We can host more events, but there's also going to be regular online chats on the NHS Futures platform. So the kinds of things that this raises for me is what kind of special interventions will be needed given the widespread nature of the pandemic and the prolonged nature of it. I think it's going to be much more extensive than just PTSD. So how do we know what kind of interventions would really benefit us? How can leaders do what is required and yet still engage others in the process? And this is kind of thinking about sometimes, you know, when systems are under threat, leaders can get very kind of command and control orientated, and that might be required sometimes, but how do you balance that with a kind of empathy and bringing everyone into that decision making? And also when we're under threat, our focus really narrows, and I've seen that happen where services focus on what they need to do, and that is what they need to do, focus that intention there. But the danger is that we don't think about the interfaces and the kind of multi-system working that we know from any major disaster is going to be vital to our response. Also, you know, it raises questions for me about how we support others to address issues of inequalities and injustices. And I think the pandemic is going to highlight these in particular, and there's going to be some groups of people that are going to be much more affected by this than others. And I've seen a lot of community action and motivation to really support and reach out to those groups. And I'm hoping that we can not just land back to where we were pre-pandemic, but think about as a society what we might need to do to ease some of that, because we know that that is a big factor in people's mental well-being. Also, how do we empower groups of people to respond to the need and innovate, whilst not being completely off-piste and not being evidence-based? I think hopefully we will be able to flexible enough to allow for some innovation given the scale and nature of things. Also, I think that these issues of isolation, it's not just first-hand trauma, but people finding meaning and worth in that situation can be quite a challenge. And how do we help people to find that and support those kind of insights after we come out of lockdown too? And I've been given some thought to screening as well, how we do that in the best way, what kinds of things we need to screen for, but also in ways that don't inhibit liberty. So, where is that information collected and who gets to know if somebody's struggling or not? Because obviously we might need to monitor populations. We might think we need to monitor populations so that we can help them, but some people might not feel comfortable with that. So I'm thinking about that at the moment. Also thinking about the best way of supporting staff so that they are able to support service users, and those normalising messages in the media that neither minimises distress but nor stigmatises extreme distress. I think those messages are sometimes a bit skewed for me at the moment. And also this idea of, do you need a separate hub for managing the demand, or that with trauma specialists in it, or do you work with the systems you have? And for the other questions, and I'm hoping that, as I said to you before, this is a kind of a beginning of a conversation where we can think about those issues together through this community. Next slide. So next slide, that's just talking a little bit about the community of practice that I know we have, I think, some more funding to keep going, so that's really good. Next slide. So let's think about who next. Can you have next slide, please? I'd like to introduce Warren Larkin, and I'll speak to you again at the end. Bye for now.
Hello, everybody. Thanks, Angela. That was fantastic, setting the scene. I'm just going to give my own personal perspective on the consequences of this coronavirus pandemic from a psychosocial perspective. So I haven't really produced any more slides, but I've got some notes so I don't go on forever. So just a whistle-stop tour of the landscape, really. We've seen an increase in family violence. We've seen an increase in domestic abuse, child abuse and animal cruelty, which is fairly predictable after global disasters. We've seen, particularly in our country, we've seen a rise in domestic abuse by about 25%. And well, that's a conservative estimate. We've seen a spike in calls to Childline, with young people wanting support and counselling around conflict at home, isolation, their own mental health concerns, and not being able to access the support that they previously had, like school and NHS services. So we're seeing, we're also seeing child abuse and neglect reports going down, and that's probably as a fact that the mandated reporters haven't got line of sight of vulnerable children and young people, which is a concern, because we know that isn't going to stop. Usually those things get worse during periods of lockdown, when movement is restricted. But there are some isolated reports from various hospitals saying that they've seen an increase in suspected child maltreatment. So some of these things, put extra demand on services. Well, all of these things put extra demand on services, and a lot of the services I'm in contact with and a lot of the reports that I read say that services already can't meet demand. Thresholds are increasing, waiting times are getting longer, some services are being decommissioned, and the whole system is under a huge amount of pressure. Add to that the impact of this coronavirus and the stress that workers are under. I worry about the worsening deficit in the NHS workforce. In 2018, there were 90,000 vacancies in the NHS alone. That is a worrying trend that's been getting worse year after year. We're also seeing people affected by bereavement and loss, not surprisingly, and this whole restriction of movement, although that's been loosened recently, some people are going to have real traumatic experiences of loss and bereavement, which they'll need to deal with, and we'll probably need to provide a source of help for. I think the fact that a lot of people manage adversity by having sources of resilience is kind of really important to note. And the key sources of resilience for lots of people are safe, stable relationships. And in this current period, lots of children and vulnerable adults have not had access to those safe, stable, nurturing relationships. And that is a problem which we're going to see emerge over the course of the kind of loosening of restrictions. BAME communities and the poorest communities in society have been affected disproportionately. We need to know more about that. It's not acceptable to say we acknowledge that it's greater. We just need to understand it and be able to do something about that. And ultimately, more children will have been exposed to adverse childhood experiences, which we know have an impact on mental health, physical health, and social outcomes later in life. So we're seeing a picture that forecasts increasing demand. Children returning to school, I think we're going to see the impact of adversity at home on those children when they come back into the school environment. We're going to be seeing reactions that staff are going to have to pick up on. In terms of NHS staff and key workers, the impact on them is going to be played out over the next weeks and months. They're putting themselves at risk. They're at high risk of mental health issues, burnout and moral injury, as Angela mentioned earlier. And we see this in other pandemics. It's a fairly predictable pattern. So we need to really think about how we're going to be able to support the workforce. And then people who survived coronavirus, 20% of those people will experience PTSD as a consequence of the interventions and the experiences that they've had. And then if we look at people who've already got mental health problems, chances are they're going to be exacerbated. And we know from reports and services that they're seeing increased need from people. And then the final layer, before I try to come to some suggestions, is recession and poverty. Whenever we see recession and poverty, we see increased demand for services. The Centre for Mental Health predict that if we have a recession similar to 2008, we'll see 500,000 more people needing mental health services. And it seems like services can't cope already. So that is a massive concern. In terms of what we can do to respond, schools, in a nutshell, focus on safety, connectedness and relationships, safe, stable adult relationships, forget academic catch-up, focus on emotional well-being. This whole idea of asking what's wrong with people is not the right question. Asking what's happened to somebody is clearly the right question, and I know that's kind of, I'm preaching to the converted. But also, like Angela said, not pathologizing reactions too soon. Lots of people are finding this scary and upsetting and unsettling. Children are going to come back to school fearful and worried and insecure. Let's not rush to pathologize that. Let's keep a watching brief. Let's understand that people over time process things with support, and most people will recover, but will be a significant number of people who won't recover from the social and psychological impact of this period. And we'll need to have a coordinated, joined up plan. So I think that's all I want to say, really. What I do want to say is that we know resilience is the antidote to adversity. And one of the things we can do is have a cross-sector, multi-agency resilience task force that brings all these different sectors, this experience, this knowledge together, and does what Angela was saying earlier, which is thinks about plans and prepares for a coordinated response to this and to future pandemics, because this probably isn't the end of it. This is probably going to be a series of experiences that affect the way society operates for some time. So I'll probably leave it at that. Thank you very much for the opportunity to talk to you, and please email me if you want to continue the conversation. Thank you.
Thanks lots, Warren. We've got Joe Wilton speaking next from the Centre for Mental Health. Welcome, Joe.
Hello. Thanks, Angela. Hopefully, can you all hear me? Somebody may nods if you can. I'm great. Trying a new laptop for the first time, not the best time to do a trial run. So I'm a researcher at Centre for Mental Health, and the Centre has a long-standing interest in inequalities. So that's what I'm going to talk about today. It's well established that trauma, adversity, and mental health problems aren't evenly distributed in society. Those who have the least power, autonomy, and wealth are vastly more likely to experience trauma, adversity, and mental health problems than others, which won't be news to anyone here today. But coronavirus has complicated the picture still further because it's brought with it its own inequalities. We know that risks to physical health are higher for some groups than others. For instance, people from Black, Asian and minority ethnic communities, elderly people, people who are living with long-term conditions. And we also know that the psychosocial risks aren't evenly distributed. Examples of vulnerable groups include those living in poverty, those in lockdown with an abusive partner, those who've been cut off from their therapeutic support for the duration of lockdown. And as you've probably noticed, there's a lot of overlap between these risk factors that I've just outlined. And as a result, it doesn't seem unreasonable to be concerned that the pandemic has a potential to widen existing inequalities, with those who are, for instance, marginalised, disadvantaged, oppressed, or otherwise vulnerable, likely to experience the most negative consequences of coronavirus, including the worst mental health outcomes. And as part of the Centre's work on responding to the likely mental health impact of the pandemic, I reviewed the literature on the psychosocial consequences of past large-scale crises. And two of the things I'd like to briefly talk about today. First is the likely time delay before the worst of the mental health impact becomes apparent. And second is the concept of institutional betrayal. But to start with the time delay, research suggests that during and immediately after a crisis, people pull together, often kind of an outpouring of altruism, this sense that we are, we're all in it together. But after this initial phase of kind of solidarity, people start to follow different trajectories. And those who are least affected kind of have the option of and an understandable wish to get back to normal relatively quickly and put things behind them, whereas others will still be dealing with the aftershocks of the event long after the initial crisis has passed. And it's often at this point, yes, trajectories start to diverge and the sense of shared fate fades and community support begins to peter out, that there's potential for the worst of the mental health consequences to become apparent. As a result, the risk that those who are already experiencing the greatest inequalities in society not only experience the most negative consequences of the pandemic, but that they will also be increasingly left without support in coping with these consequences. Which brings me to the second topic from the research that I wanted to briefly touch on today, which is institutional betrayal. So it's a concept that's got its roots in the literature on sexual abuse, specifically the failure of institutions such as the criminal justice system to respond supportively to survivors of sexual assault. However, using the example of, say, Hurricane Katrina, it's possible to see that the idea of institutional betrayal has broader applications. And research has shown that people who had more negative views of the government response to Hurricane Katrina were also more likely to experience negative symptoms of traumatic stress, which is to say, in short, how institutions, the government, health services, social services respond to the pandemic will matter in more ways than one. If people feel let down by the response, if they feel that it's unjust or inadequate, kind of in short, if vulnerable people feel betrayed by the institutions that should be there to support them, the evidence suggests that this amounts to another psychological injury kind of in its own right, and that will only add to the negative mental health outcomes, kind of making a bad situation worse. So to sum up, some of the questions we're concerned with at the Centre for Mental Health at the moment are how do we prevent the pandemic from widening existing inequalities? How do we respond to the psychosocial impact in such a way that those who are most marginalised, disadvantaged, oppressed, isolated, vulnerable, receive the support they need and aren't let down by our institutions? And those are the couple of questions I wanted to raise today. Thank you for giving me the opportunity to talk.
Thanks, Jo. Really important issues there. Now I'd like to introduce Bob Balfour.
Hello. Can you all hear me? Can you hear me, I presume? I'm Bob Balfour. I'm the manager, chief executive of a small charity in West Yorkshire that's operated for 20 years, working in a trauma-informed world. So our world has always been trauma-informed. I'm an expert by experience at the University of Liverpool in a research group for clinical psychologists, students looking at post-traumatic growth. One of the reasons I chose the title for this presentation screen, I did very quickly, because in my mind, is we weren't prepared for a pandemic, clearly. And I think the consequences of the pandemic, beyond the biological effects, the trauma effects, we really need to be prepared for. And I just don't mean in the context of sexual violence, I mean in the context of trauma. And what sexual violence services have seen over the last 20 years is trauma is like a virus, especially its disclosure. Once people begin to feel culturally free to do so, it is kind of like fluidly dynamic, and it goes in ebbs and flows, and it rises up. So it's not a tidal wave, though it can feel like that at times. It's more like a surge, and the speed of the surge depends on all sorts of dimensional factors in relation to individual and community and social forces. But once it begins, it's very clear from the data that it won't stop. The latest thinking from criminal justice is that disclosures of sexual violence in particular are not going to end, that they are just going to carry on. And the trauma people experience from the lockdown, for instance, for lots of survivors, isolation is something that they can actually really deal well with. But for many, many others, it's very, very difficult and very frightening. And those fears trigger all sorts of other anxieties, I'm sure you'll all be aware. But I actually think the solutions are to look beyond what we construct as evidence in relation to NHS perspectives, and actually have a look at the evidence that goes back to classic times about how you deal with collective trauma. And I think those lessons are there for us throughout the literature of history, and how people both heal individualistically, but also collectively. And Warren speaks very eloquently about, it's the relationship that heals with a great deal of passion. And I think that relationship is not just individual, it's collective. And I think that's where you need to start thinking about solutions that are curative and collective, and actually driven by the people who've experienced the trauma, rather than a clinically led process, clinically supported process, clinically empowered process, resource process. But people will heal each other. And I think that's where we need to be thinking. I think I'll close at that point, otherwise I'll pretend to be an academic or something, and that wouldn't be very good.
Thank you, Bob. It's fantastic. I'd like to introduce now Sally Smith, who I'm honoured to work with in the same trust, and you.
Thanks, Angela. I apologise to everyone. I'm shy and awkward at the best of times, so please forgive me if it seems like I'm trying to ignore that you're all there. I think it's so encouraging to hear so many conversations about the psychological impact of the pandemic for the population, and such an awareness in communities of the potential effects on people's mental health. However, as other speakers have alluded to, I'd urge us to think about what the impact of this time might be on those already facing multiple disadvantage, those who are already living with the aftermath of trauma, who've already suffered because of abuse, neglect or oppression, those perhaps most disabled by their mental health problems. As with so many things, the pandemic seems to exacerbate inequalities, and perhaps the most vulnerable are disproportionately affected and at risk of greater psychological harm. In my work role, I've had the real privilege of chatting with local service users over the past few weeks and months to try and build a picture of what they've been experiencing. These conversations, plus data from national surveys and blogs, seem to build a picture that COVID and the response to it is, in the majority, having a detrimental impact on service users' mental health. Some worrying things are starting to emerge around growing demand on voluntary sector helplines, increased self-harm, suicidality, drug and alcohol use. Whilst there'll be huge variation in people's experience of lockdown, it's perhaps not rocket science to contemplate that many people are struggling with the isolation, the loneliness, the lack of connection. Many people reported having lost their normal routine, the activities that keep them well, their tried and tested coping mechanisms. People reported increased fear, anxiety, paranoia around the contagion, but also around fear of death, loss of loved ones, anxiety about the future, and about returning to normal and what that might be. People talked about the strains on relationships in their household, feeling like they were living in a pressure cooker, people with eating distress feeling triggered by food shortages and inability to get safe food. Many people shared concerns about accessing practical help and their financial situation. Another key thing that I found in my conversations with service users was the reduction in support people are currently receiving. Although people were really compassionate towards services in these circumstances, most people I spoke to described a significant reduction in support. Many described some remote contact with mental health services, but that the phone call didn't feel as therapeutic as their usual visit, that the feeling listened to, the feeling validated, understood, cared about was missing, that the 10-minute check-in didn't provide relief from the isolation and loneliness. People spoke of the difficulty of reaching out for help and having tough conversations while stuck with family at home. Some people frightened to access face-to-face support because of transmission of the virus, worried about going to A&E and facing increased stigma. And one overwhelming piece of feedback was that people did not want to burden services, burden the NHS, that they didn't want to ask for help because of the shame and guilt. I think it's fair to say that while services clinicians may be doing their best to operate remotely, it can still also be true that many service users are experiencing a real loss in support. As a trauma survivor and someone who's relied heavily on mental health services for nearly 20 years, I've found elements of lockdown to be really triggering and frightening, and in ways that I didn't anticipate. Early on, I found the powerlessness and the forced quarantine really replicated the feelings of being detained on a ward. I experienced lots of flashbacks and nightmares and would wake each morning with that sense of absolute dread in the bottom of my stomach, the worry of just sitting with my own thoughts all day with no routine or people to distract me from it. And the sense of crisis and heightened panic that's felt in everyone else felt so familiar. I had to keep reminding myself that I wasn't in crisis and that I was okay. And some of the most traumatic things that have happened in my life have happened in this house. So it's hard feeling trapped here with no way to get distance from that. And occasionally that feels overwhelming. And as someone who's survived multiple suicide attempts and sort of regularly dances on that edge of needing to escape, I have lots of well-rehearsed things that I know help me and provide release, and things that now I can't access in lockdown. My space to offload is gone, and living with that is a worry. What if I hit crisis? What if I need to be admitted? The shame of being someone with a PD label means I'm frightened more than ever that right now I'd be seen as an attention seeker and a time waster, that amongst all the real suffering that's out there at the moment, that I'd be a burden. A number of fellow survivors have shared with me that they've experienced similar things, that the lockdown is causing a lot of distress, the sense of powerlessness, the feeling trapped, the isolation, the anxiety, and the stress was all triggering a trauma response for them too. I'm lucky to be in a really fortunate position right now, but I am worried for many of my friends and peers who are trying to hold on during lockdown with very little support, and the uncertainty about how long they might be in this position is also hard. My take-home message from my 5 minutes a day for colleagues on the webinar is, please let's not forget about people who were suffering before the pandemic. And in order to offer support that helps people heal, let's strengthen our focus on working together and really listening to what matters to trauma survivors. Thanks. Thanks for having me to speak today, Angela. Thank you.
Thank you.
Thank you, Sally. Now I'd like to introduce Jasmine Siddal, psychologist.
Hi, thank you for that really moving talk, Sally. Okay, so my name is Jasmine Siddal. I'm a forensic psychologist, and I've been asked to speak for a few minutes about the psychosocial aftermath of the pandemic. Obviously, this is a huge area and not something which can be covered in only a few minutes, so I wanted to narrow my talk down to a very specific area. To consider the relationship between people's experience of their loss of liberty as a result of the imposed restrictions for the pandemic, and how this may impact on the way those in a caregiving role may relate within forensic settings. This is an area which is aligned with my own personal values and interest, compassion, or more specifically, compassionate care and compassionate leadership. It's also an area which is quite specific to my work setting, a forensic secure environment, an environment which by its very nature is a restrictive environment where residents experience a loss of liberty given the nature of their detainment. Liberty is the ability to do as you please. It's the freedom to live your life the way that you want, without interference from other people or authorities. In a book chapter he wrote in 2018, Lawrence Jones compared the process of surviving environments in which there is a loss of liberty as similar to the bereavement process. This is because the loss of freedom is closely associated with grief or loss. Kubler-Ross proposed different non-linear stages to grief: denial, anger, bargaining, depression, and acceptance. Early on in the pandemic, Scott Berinato published an article called "That Discomfort You're Feeling is Grief." In this article, he summarised an interview with David Kessler, who previously proposed a 6th stage to grief, meaning. Kessler acknowledged that we're all feeling a number of different griefs. The world has changed. The loss of normalcy, the fear of the economic toll, the loss of connection, anticipatory grief, or anxiety of what's to come. We're all grieving, collectively. To help manage this, Kessler advised us to stock up on compassion. Paul Gilbert identifies that compassion consists of 6 attributes: sensitivity, sympathy, empathy, care for well-being, distress tolerance, and being non-judgmental. I often hold in mind the phrase, compassion is an antidote to a threat-focused mind. A threat-focused mindset which many of us may have experienced at some point in this pandemic. As empathy is one of the attributes of compassion, I would like to focus on this some more. Empathy is the ability to understand and feel what another person is feeling. Although it is not essential, it is much easier to empathise or relate with someone if you have lived experience of what they've been through. Given the restrictions in place for the recent pandemic, I am speaking about the loss of liberty that we have all experienced to some degree, whether it's the loss of freedom to visit family and friends, or the loss of freedom to shop as and when you please, or even the restrictions on our movements, the amount of exercise we can do. This loss of liberty has been unprecedented for many. My hypothesis is such: I wonder if the loss of liberty caregivers in forensic or secure settings have experienced as a result of the restrictions placed on them to reduce the spread of the virus is paralleling some of the restrictions many of our residents feel in secure settings. And I wonder whether this parallel process may impact in the short and longer term on their level of empathy and thus compassion, and whether this will also impact on the quality of the therapeutic and working relationships in the short and longer term. Within my own leadership role, I will seek out opportunities to highlight the paralleling experience, to further enhance and nurture empathy and compassion within the service. I will also look for opportunities for trauma growth and how that might counteract some of the more difficult effects of the pandemic, such as compassion fatigue and burnout. I welcome other people's thoughts and ideas on this topic. Thank you.
Thank you, Jasmine. That was really interesting.
Thank you.
We have a little bit of time for a panel discussion. We do have one more speaker, but we are expecting that to be quite inspiring. So we're going to leave him, but feel free to join the conversation, Nigel. Any questions that have popped up for the panel? I had one that seemed to resonate. You know, this idea that we're all in this together, and we are in this together up to a point, and that we're all potentially at suffering from the pandemic and some effects of it. But I feel fairly privileged. I'm continuing to get paid, so I don't have those financial worries. I'm not in a high risk group if I catch it. I think I've had it. And I wonder whether that narrative of that we're all in this together is a little bit misleading. I wonder what the rest of the panel think about that.
Hi Angela, it's Beth.
Hi.
Hi, I can go really quickly, and I think it was Warren who picked on this specifically in his presentation. I think you're probably right. It's probably quite a quite a misconception. I think, as we already know, people who are from marginalised communities, or who are, say, particularly from BAME or from lower socio-economic backgrounds, tend to be more impacted by these sorts of situations. And I think, as Warren and others have emphasised, we will see that over the course of the response to COVID, definitely.
Yeah.
Warren, I think, raised his hand to make a point.
Do you want to speak, Warren?
Just briefly, yeah, thank you. I completely agree that there's a sense of solidarity at the moment, and particularly if you work in a large institution, you feel like everyone's pulling together and doing the impossible. But I think socially and psychologically, there are massive disparities. You know, people who are from certain sections of community, the poorest in our society, Black and minority ethnic groups, are at higher risk. There's no clear plan about how we can protect and support people who are at higher risk at the moment, because they don't fully understand it. And I think there's a huge difference between living in a home where you feel secure and safe, and you've got a private outdoor space, and you're not worried about money, compared with somebody who's living in, you know, a flat in the middle of a built-up area with no access to private space in a really stressful home environment, where you're worried about whether you can pay the bills and feed the kids, you know. So I think I agree with that idea that we're going to see this divergence of the haves and have-nots in our society, and that'll be people who are economically and financially disadvantaged, but it'll also be, the difference will be clear for people who've been through adversity and trauma and people who haven't. And I think we're just going to see a huge upsurge in demand for services, and then if recession kicks in, God help us, you know. And I just think we need a national conversation and a plan, because once the immediate risk of the pandemic subsides and we kind of go about our business in a more regular way, that's when this is going to become evident, and that's when, you know, services and people and society are going to start struggling to cope and function. So I think we need, you know, that collaborative. One of your points was about, you know, what's the right response. It's a collaborative cross-sector response with a government mandate that says we've had a really, you know, we've all pulled together for this virus and the impact, but actually, what about the social and psychological consequences of this? Because they could last for years. Based on economic evidence and analysis of adversity and what that does to society, it could cost us a lot more dearly, actually, if we look at it across the next generation. So, sorry, I lied about it being brief. Apologies.
That's great, Warren. Thank you. I agree with that. I think Paul Turner wanted to come in with a comment. Paul, do you want to say something briefly?
Yeah, thank you. I'm a GP in Birmingham and mental health clinical director in the West Midlands, and I agree. Really, I'm in alignment with what Warren's just described. I think one of the biggest problems we've got here, though, is that, and it's really interesting listening to all of you speaking predominantly, I think, from a perspective of specialist services. From what I can see, although it might be completely wrong, that the first layer of intervention has got to be in primary care from a healthcare point of view, because the people you're describing, the people who are most at risk, often don't have the words to describe what they've just been through. They don't walk through the door and say, I'm suffering with grief. They come with physical ailments. They come with a whole range of other things. And we don't have this national strategy that Warren just alluded to. We've got stuff in the long-term plan, but it doesn't add up to a strategy. And I'm very disappointed with it. And I work for NHS England, and I've told them, and I will keep telling them, because people will get piecemeal approaches to putting in trauma-informed approaches into little aspects of specialist services here and there, but pivotally not to the place where a lot of referrals come through, A&E and general practice. I've just come from a call with the all-party parliamentary group on adverse experiences, and it is extraordinary what is going on in some parts of the country. Police, public health, education, there's streets ahead of us in terms of early intervention. Now we've got to have a mandated and really clearly articulated and with a training process for trauma to help people who, as frontline clinicians and other services, just don't know how to deal with this, and they will be instantly overwhelmed.
Mm-hmm. Thanks, Paul. There's a question come up here. Does the panel have thoughts about whether we need COVID-specific services, or should we incorporate that into services as usual? It strikes Elena that specific services, specialist services around this might fragment further without boundary spanning work. Right, across boundaries. I wonder what the rest of the panel think about that. I mean, my view has changed a little bit recently, because I had previously thought it probably wouldn't be a good idea. But I think there's two things that I worry about. One is whether or not our services that we currently have would have the skill set or the capacity to meet the COVID-specific demand, and also whether those people who have been in those services for a long time and continue to need those services might get pushed to one side a little bit by that. So I'm coming round to the idea, actually, and I've been listening to a lot of the learning from the Manchester hub, and they plug the gaps of other services, and I think it's not about replacing a service with something specialist, but it is about having something that does plug those gaps, and I think that would probably be helpful. What do the rest of the panel think? Feel free to unmute yourself if you've got anything to say. The panel.
Warren here. I think it's probably a bit of both, really. I think it's going to be impossible to kind of categorize people as to whether their problems are, arising out of the pandemic situation or whether they were pre-existing or, related to something else. I think we just have to accept there's going to be a huge increase in demand and get that balance right between not pathologizing people who are understandably distressed and upset because of the circumstances and what they've been through, and having trauma-specific interventions available for people that need them. And I think that's a problem we've already got. People can't access interventions for trauma when they need them most of the time. So that can only get worse. So I think I agree with what Paul said earlier. We absolutely need a plan, a mandate from government, and some funding and action to go with it, because when people come to primary care, for example, the worry is they'll end up being prescribed antidepressants, because there's what's the option? You want to try and help, but very often that isn't going to help in circumstances that are created. The distress is coming out of real things, circumstantial, environmental, economic, relationship issues. It's not a sign of a mental illness, it's a sign of a sick society, I suppose. So yeah, I think probably we need the bigger picture plan to address all of that. And we need to treat this just as seriously as we have the medical implications of the virus. And I'm not hearing a huge amount of discussion about it when I hear the Prime Minister's briefing. I think there was one comment about Mental Health Awareness Week the other day, which was nice, but it's not enough, is it? Let's be honest.
Okay, so I think we should continue this conversation, and I'm going to set up a kind of time for people to join a chat on the NHS Futures platform. So let's keep this conversation going. The reason I'd like to introduce Nigel to you in a sec, but there's a reason why I've left him to last, and that's because I've worked with him a little while now, and he's so inspiring that I thought it would leave us all on a bit of a high, uncontaminated by difficult questions. And so yes, I will hand you over to Nigel Osborne, composer, aid worker, all-round good guy as far as I can see.
Thank you. One wonderful introduction. Thank you very much for the invitation. I'm here, I think, because of an earlier invitation to Angela's summit last year on trauma-informed care, where we decided that probably there was some point in some knowledge sharing between aid work approaches to trauma and those that are happening in the health services. We certainly need it from the aid work point of view. My goodness me, we need it. And maybe we have a few little things to offer. What occurred in the meantime is we've actually done it in the sense that Angela, in her usual visionary way, opened the door for us to start a music self-care site on the Recovery College website. And this, in a sense, derives directly from our work with traumatized children in zones of conflict. You standing there, you see the picture. It's where I should be standing now, which is why I've given you a picture of myself. I should be in the Bekaa Valley in Lebanon and cannot be, and I wish I were. I work with the children and communities there. They are Syrian refugees who've been there now, they're in their 10th year. As you can see, they live in tents made of plastic bags, tarpaulin, and matchwood. Half of them have no support whatsoever from the international community. The UNHCR support that goes to the other half is £13 a month for food and only emergency medical support. The rest we have to support with small NGOs. I have a music program, and we've been working with the children with that, with some success, and I'll describe it in a moment. I was going to show you a film, and it's nobody's fault, it's to do with transferring technology, but I was going to show you a little songwriting session with some of the children, a song that they composed. I'm going to sing it to you. Surya hoppari hayataman. Syria, the land of love and peace and the warmth of home. The lovely thing about that song is we established some schools for them, and in the song it goes on to say, and we feel that when we come to school, we're coming home. And we were very happy with that thought, that we provide the place with windows and chairs and a roof. For people who have plastic bags to live in. Could I have the next slide, please? There's another slide, I think. Yes, great. Oh, that seems to have jumped around a bit. Okay, never mind. That's interesting. We were having success with this work for many years, and so it sent us back to the science, to the medical science in particular. I'm part of a background in neurology. And we discovered some very interesting things. The literature was developing, and we were able to make, you can't read it there, but we were able to make a kind of model which took us from the biological effects of music on trauma, and let's say these manifest themselves in children very strongly. For example, dysregulation of movement repertoires, getting either being very sluggish or very hyperactive. Autonomic dysregulation, being on alert the whole time with high tone in the the sympathetic division of the autonomic nervous system. Endocrinal dysregulations around things like cortisol, but many other parts of the body chemistry. And movement, as I mentioned, sluggish or hyperactive. So we have various things that we found we could have good effects in music and on other things. You can't read it there, but things like what we're discussing: compassion, empathy, trust, building self-belief through creativity, socialization through being together and helping. Music's a great place to be together. And so we developed this model, which has been relatively, and it's got good science. We were lucky that the science came as we were doing it. Then that allowed us at one stage to automate, which is where we get to recover. What of this could we bring back home, and what could we automate? Because actually it's essentially a very human process. It's to do with being with people. It's very, very human contact based. So how on earth do you automate that? Well, we kind of can. If I have the next slide, we built a model of the musical brain. And we've learned quite a lot about it, there again, through the good fortune of a big expansion in the neurosciences and neurophysiology of music. And we're able to we don't know the neuroanatomy of Haitian's Jarrett, but we know enough about it and know what goes in and what comes out. And we can model it in that way. And so we built a model of the musical brain that enables us to predict fairly accurately how it will change somebody's heart rate. We're very accurate on that. How it may also affect their feelings, their moods, and so on. We're able to predict it. And it's a universal tool. It does not take into account individual experiences and preferences. Much of our music comes from what we've experienced as we listen to it, or from our culture. It does the other bit, the universal bit, that we tend to underestimate. We are much more musically universal than we think we are. And in fact, I think we're generally much more universal than we think we are. I think the human brain is identical in every creature, human creature, walking this planet. And therefore we can talk to it in the same way in certain ways. So we built this, put it onto the Recovery College, and what we have is playlists that we've done that use the system to predict effects that will take people through things like just relaxing, enlivening, or indeed we now have depression and trauma lists.
Thank you so much for that, Nigel. Yes, if anyone wants to join us tonight, I've posted the Zoom link on the chat, but we can also get perhaps Anne to circulate the link to you by email, if that's possible. But I've just posted it on the chat there. It's quite easy to join. You just click the link, and you don't need a Zoom app or anything like that. I've got an amazing singer tonight with some good songs. Thank you. That's it for us. Let's continue the conversation on the platform, and we will host some more webinars. If you have any ideas for topics of webinars, let me know. I've had a few. So thank you very much.